Listo.
Perfecto. ¿Estamos listos entonces, Pedro?
Sí, pueden comenzar.
Muy bien. Hello, everyone. Thank you very much for accepting our invitation to our IFSO LAC webinar. I'm going to do just a little presentation of what we're going to talk. Which cases are the best to reintroducing the elective bariatric surgery? For this, we have the privilege to have Luigi Anglisani from Italy, Ricardo Cohen from Brazil, Nathan Zudel is our moderator and boss, Amino Ramos from Brazil, and now we are here just to present these guys. So, Nathan, the time is yours. Thank you.
Thank you. Thank you very much, everybody, for taking your time for...
Volumen, Nathan.
My volumen? Can you hear me?
Yes, we do.
Okay, so thank you very much, everybody, for being here in this seminar. I think that even a lot of people tired of webination or start webinando. It's the only way we can attend and be active while we start to make a real living again. For us in the US, we already start to open some cafes, some restaurants, some beaches, some parks. So hopefully soon we'll renew, we start elective surgery also. So hopefully we can start to make a new living. But it's not the same for the rest of the world. And it's not the same for every state, every city, or every hospital in the country. So IFSO Latin America invited an amazing group of people to discuss how they envision, what are probably the best cases, maybe according to their own scenarios and their own situations in their cities, their countries, and the hospital. So we're gonna have Luigi Angrisani from Italy. Luigi is a past president of IFSO. We know him very well, and Italy is one of the countries who got hit hard for this, so he will explain his point of view. We have Almino Ramos, also past president from IFSO. Brazil was doing more or less okay. Now it seems the situation is a little bit different, so Almino will explain how they're planning to handle this. We have also other people. We have Pachan Vivek. Hey, Pachan, long time no see, man. So he's also in one of the places that has been hit a little bit hard in the US. So he's gonna let us know how this comes. So we're gonna see all the presentation, and then we're gonna discuss what are the best ways to do this. We have Ricardo Cohen, that he put a background that probably is his house in Bahia. I don't know where he is, so I'm gonna put mine in Miami when I'm not there. So then you don't give me envy, because now I can look better in the beach. So we have a very good group of experts. So let's start. Pedro, Estuardo, thank you very much. Let's start with the first presentation. I think it's Luigi. And which cases are the best to reintroduce in elective bariatric surgery? Low morbidity case. Welcome, Luigi. Grazie.
Thank you, Nathan. Thank you, everybody. It was really a great pleasure to be with all the Latin American family. We always used to say that Spanish are more than only cousins to the Italian people. We are brothers, because we think very similar. We have similar views in many things. And so tonight I'm going to share with you what I have been working more than 2 months ago, when we were at the top of the COVID infection crisis in Italy, and we were completely shut down and locked down, and the bariatric surgery was stopped. And I tried to think what would be the best for restarting. I have no conflict to declare. And in these slides, I'd like to point out that the era we are living, it is similar to what happened at the beginning of the last century, in 1918, 1920, with the Spanish flu. And what is also very important is to take in mind what is the Hippocrates classic oath, where he was clearly stating that it's not always for a doctor to do what is proved by science or knowledge, but at some stage he has to do things that is basically creating on his experience. And so we are in a phase where now we know something more about COVID infection, coronavirus infection, but at the beginning, 2 months ago, we were in a difficult situation. So it is quite clear that the level of spread is variable. In Europe, it was like this. I guess it's the same in South America, and many countries have stopped the bariatric and metabolic. And of course, we start by the concept that surgery is contraindicated in SARS-CoV-2 patients. This is an example that I took from our own experience to show how in one country the rate of infection was so different between the area where Milan is, Lombardy, versus the area where Naples is in southern Italy, where Campania is the region that we have. The rate of infection has been completely different. The rate of occupancy of the ITU has been completely different. Basically, we had a much more mild type of pandemia that he was presenting in northern Italy. And this is important because I think we need to respect also national and regional variation in the incidence of the virus to decide which operation to do and when to do. The other point I'd like to address is the definition of the transitional period, because of course we had a high rate of infection and a high occupancy of ITU, a high mortality, so this is not the period to do anything. But after that, there is going to be a transitional period where the virus is not to disappear suddenly, and we need to define what is the transitional period. And this basically the phase of deceleration of the infection rate, where of course the ITU are working in a more normal and relaxed situation. So I took to define the ability of receiving patient, of working correctly in the ITU, this critical level that was just designed in London, just when it was designed not many years ago, in 2009, for the H1N1 influenza pandemic. And this is designed to assure that the unit do not reach the top of the occupancy, and basically this was designed to avoid that patient who need ITU was denied to have such a treatment. So I guess this slide is not easy to read, but this is a classification, and basically it is quite clear that we need to consider to restart bariatric surgery to be in a phase like criticon 0 or criticon 1, where you have normal situation in ITU, so business as usual, but you don't want that you are in critical 1 phase where they define this bad winter, because if this is the situation and you are operating a bariatric patient, especially a complicated bariatric patient, because that's the point, that some people are considering to operate the more complex patient. I would privilege the more simple, straightforward patient. Of course, you don't want to go, when you do a complex case, to risk the fact that this patient need to be in ITU. And of course, all the other situations, critical 2, 3, or 4, are obviously situations that we don't want to reach in any case. The other interesting way of measuring the opportunity to start bariatric surgery was, I took these slides with permission of Dr. Feng Chang from China in one of our last IFSO webinar. And you can see that it is quite clear that at level 3, 4, and 5, you should avoid bariatric surgery. So you should be at level 1 to consider the possibility. And of course, all patients should undergo screening protocol, and cross traveling provinces discouraged. And of course, any hospital with case should avoid bariatric surgery. And we are slowly addressing the point that I think I wouldn't go into that, because we know that the American College of Surgeons has defined, with the ISMBS, has defined what is emergency, semi-elective, and elective bariatric surgery. We know that basically most semi-elective can become emergency situation, so we should concentrate on elective procedure. I add to this list the possibility of balloon placement that still is endoluminal, but still is bariatric surgery. So why are we going to restart? I think we all know the benefit of bariatric surgery. We all know that we don't want to wait for doing what we know can create a substantial benefit to the patient. And the other situation is that we know that the people with COVID that are obese are suffering a very bad prognosis from COVID infection. So in a way, if we are going to look into to figure out the future of pandemic viral infection, especially of the respiratory tract obesity, is really a bad situation to get the infection. So this is another indication, another reason to start the operation. And the other interesting anecdotal observation is that I think most of us have had the patient that have been suffering of COVID infection and have gone through very well because they were operated. And I have example of people that came back to me and they said, "Doctor, thank you I was lucky to have had an operation for bariatric surgery because the anesthetist and the doctor that was looking after my care said that you should not have survived being super obese or morbidly obese." So when are we going to start in a deceleration phase when the virus is decreasing its rate of infection? In Naples, we are almost at R0 now, but certainly we should, two weeks ago, we were on a deceleration phase. It would be very good to define, we have done this in Naples and in most places in Italy, identification, classification of COVID positive and COVID negative hospital. Otherwise, you should have one wing of your hospital dedicated to COVID negative patient. And the other nice observation is to have a criticon level from 0 to 1. So most ITU can work under standard situation and standard of care. So the restart should be gradual, and if I should be how prioritize patient, I would prioritize straightforward case with avoiding in the first case complex bariatric, revisional, severe comorbidity because of the risk of postoperative complication and mainly ICU. So who is eligible in the transitional phase? The transitional phase may vary from 2-3 weeks to a month. We are in a phase like this. Yesterday, after 3 weeks of normal standard operation, I did a revisional case, in quite complex case, but everything is almost equal to normal now. So if I would be 3 weeks ago or 4 weeks ago, I would say asymptomatic patient, no flu symptoms, no fever, no GI symptoms, no, of course, history of COVID infection, age 20 to 50, because we know that over 50, there is more risk if you get the COVID infection. BMI, low BMI, we tend to be below 60, better be below 50. And no comorbidity, I would avoid diabetes, hypertension, and cardiac disease. At least if you should consider diabetes and hypertension, they should be compensated, perfectly compensated by the medical treatment. And no severe pulmonary disease, possibly no smoking. This is the idea. These are some slides I have here regarding the management. Of course, we all know outpatient, body temperature, COVID-informed consent, nasopharyngeal swab, where is possible. I can honestly tell you that in southern Italy, swab are not easily available. I am operating people with no symptoms, no temperature, and only on serological test. Radiological evaluation, X-ray is standard X-ray, of course, possibly ultrasound, very good. I would CT scan, last option, if you really don't have other way. Telemedicine, of course, patient allocation, minimal 1 patient per room, maximum 1 relative during the hospital course. In the consent, clarify that they have an increased risk of getting the infection. They must agree to be screened and must agree on self-quarantine for before 1-3 days and after the operation for a minimum of 14 days. Equipment, I leave to you the decision. I know the only thing I know is the eye protection set is very expensive, and this is a problem because, of course, for me, I left the National Health Service and private practice, so people are very conscious about the cost. Post-operative management, all life, I would consider ERAS protocol, possibly nasopharyngeal swab before discharge, self-quarantine post-operative, supplementation, meticulous supplementation because of risk of major vulnerability during the fast weight loss period. Reduce the number of procedures. If you are used to do 4-6, I would do 2, maximum 3 per day. and definitely bariatric surgery will definitely suffer of a considerable reduction in the total number performed worldwide. Conclusion, restart is a delicate process, has to be gradual and prudent, and hospital must prepare specific internal protocol. Of course, there is a variety of regulation that your regional health local authority or national authority will give to you, and we must respect that. And surgeons should rely very much on their clinical sense, surgical capability, and work according to the regulations that are established by local departments. Thank you very much for your attention.
Thank you very much, Luigi. Before we move on to item first one, all the question and discussion will be at the end. Second, we need to do this quick poll. Please answer these questions while Luigi leave the screen. First one, are you doing elective bariatric surgery at this moment? Yes or no?
Shall I answer?
Everybody should answer. Second, what kind of criteria for selection do you use? No selection criteria, low morbidity, high morbidity, or Merck score? Pedro, I cannot vote. I don't know what's the reason.
No, we cannot vote. Host and panelists cannot vote.
We are in 62% of the
Perfect. Okay.
limit.
So I suggest Ricardo Cohen, that is next, start to share the screen. So the next presentation will be from Ricardo Cohen. It's called High Morbidity Cases, Disease Burden Centered. Ricardo Cohen from Brazil. Now you can see the result of the polls now.
All right.
Perfect. Okay, good. Thank you, Ricardo. Please start.
Thank you. Thank you, Nathan. Thank you, everybody who's here. Well, I'm going to speak on the risk stratification of obesity and diabetes for prioritizing patients for surgery. Those are my disclosures. And we had no strategy during the peak of the pandemic. But as soon as we resume elective surgery, we need to build a strategy. And most of the people around the world, including healthcare providers, think that metabolic and bariatric surgery is just a bunch of procedures. And there's a waiting list paradox. If you look at colectomies, cancer, diverticular, inflammatory bowel disease, polyposis, they do not go on the same wait list. While in bariatric surgery and metabolic surgery, whatever is the associated diseases, high BMIs, type 2 diabetes, NASH and metabolic syndrome, or even adjuvant pre-transplant weight loss or metabolic control, they go on the same weight loss if first come, first serve patient. So I think we need to think about this because this is a huge opportunity to show that metabolic and bariatric surgery really saves lives. Why I'm talking about this? Exactly because there are huge bias and stigmatization against obesity, because there's a considerable number of people, including healthcare providers, our peers, that still think that obesity and all comorbidities are a matter of choices and bad behaviors. And we know this. If you go to a funnel where a lot of operations that are quotes, urgent and may save lives, we have a huge wall that does not allow us. And this is regular practice. I'm not talking during the pandemic. Our penetration is less than 1% because most of the people around the world think that obesity and its comorbidities are not diseases. They're just, again, bad lifestyle choices. But there are a lot of medical complications that come from obesity, at least 236. Among them, I'm going to speak only about two, obesity itself and type 2 diabetes. Should we prioritize this gentleman? He's 37 of BMI. He's very physically active. He sells stones. He's employed. He has a controlled blood pressure. His A1C is below 5.5. Well, this one, it's his boss. He has a BMI over 60, NASH, hypertension, severe obesity, hyperventilation syndrome, and he refuses to undergo CPAP. He has heart failure, that's why he does not walk, and chronic kidney disease. He's pre-dialytic. And if we look at obesity itself and its mortality, let's look at the Edmonton Obesity Severity Score, where this was produced by Arya Sharma from Canada, and others just follow him. And he classified obesity severity into 4 stages. Stage 0 is where there's no medical, mental, or functional problems. Stage 1 is the pre-clinical risk factors. Stage two is the established comorbidities. Stage 3, patients have already end organ damage. And stage 4, there are end stage diseases, where surgery or whatever clinical measure is almost heroic. Let's look at the shares from overweight to class 3 obesity among the Edmonton severity scores. Look at, it's very interesting. The vast majority of patients with class 1 obesity, they has EOSS stages 2 and 3. So they're really sick regardless of their BMI. If we look at the enhanced classification of mortality, this is patients surviving versus 200 months. Look, there's absolutely almost no difference between mortality if you classify them among their BMI classification. Again, just to remember you, from 0 to 4, from no apparent risk factors to subclinical, the real established obesity-related chronic diseases like type 2 diabetes, hypertension, and this is what really kills all viral infections, including H1N1, influenza, or even the new coronavirus. And stage 3 is the established and organ damage. Let's look at the EOSS classification. Look at those numbers. Those are mortality related to BMI, and this is related to the severity of the disease. So the disease is more important than the mere comparison between, or the math between weight and height. Let's switch gears to diabetes. Obesity is pretty easy to show you how to stratify the risk. Diabetes is a major cause of morbidity and deaths, mainly from cardiovascular events, kidney problems, neurological, and retinal complications. 2/3 of patients with type 2 diabetes die from cardiovascular disease. This is a very interesting report. And insulin resistance is the background of type 2 diabetes. However, when beta cell function declines, diabetes becomes clinical detected. So EOSS 2 and 3, they come from the preclinical insulin resistance to the EOSS 3 with established diabetes. So this is a graphical way to show you this. Insulin resistance just go up, as well as blood sugar, and beta cell function starts to decline at this point where metabolic surgery really works most. If we look at the predictors of mortality over 8 years of follow-up in patients with type 2 diabetes, among over 8,000 patients, you see that all-cause mortality is older age, male, non-Hispanic, white people, greater duration of diabetes, lower BMIs, by lower they mean from 30 to 35, hypertension with macro and microvascular disease. So previous cardiovascular events and chronic kidney disease due to diabetes are causes of all-cause mortality. And if you look at cardiovascular mortality, insulin use is the sole predictor of mortality. It's statistically significant. While higher LDL, history of kidney disease, stroke of transient ischemic attacks, coronary artery disease or peripheral vascular disease, and the use of statins or anti-hypertensive drugs. So with this huge database, we can see that mortality is related to the severity of the disease and not the BMI of the patients. So we have robust evidence that patients with end organ damage should be prioritized. And I have to remember you, priority is not eligibility. We are here, probably most of us are bariatric surgeons. I don't have to convince all of us that bariatric surgery saves lives. However, this is not what's perceived by our peers and by the general public. Remember again, our penetrance is less than 1% worldwide. Exceptions are Kuwait and Belgium, but even though they're less than 30% of penetration. So remember, to prioritize patients is not to to gauge them how eligible they are for surgery. So we need a triage system, because if we delay some operations in some patients, this may harm patients in different intensities, mainly related to the severity of the burden of obesity and type 2 diabetes. BMI-centric criteria, they do not fulfill those needs. We need to prioritize according to the burden of disease. That's obvious. The patients that are time sensitive need to go first. And we need to gauge this with the likelihood to improve after surgery, because it doesn't matter a patient with end-stage organ disease. Well, I mean, dialytic patients, they would benefit from this. But pre-dialytic patients, yes, there's some evidences, although they're not level 1A, they're level 2, but there's robust evidence that yes, we can add improvement to those patients. This is an example of the Brazilian Society of Cancer Surgery, when they decided to go to our health authority. I was there in this meeting, and they just compared our operations to non-essential elective surgery, like plastic surgery, vasectomies, infertility procedures, and bariatric and metabolic surgery. I can tell you that today will be published in 1 hour our prioritization criteria, very matching to what I mean, because this is why we gain respect with our peers regarding the importance of bariatric and metabolic surgery. And this is why we came with this Diabetes Surgery Summit group with some ideas or recommendations how to manage surgical candidates and how to prioritize surgery to access surgery for our patients in need. Well, we classified surgery as urgent access, surgery within 30 days, with conditions with potential to deteriorate quickly. Here are some examples. Expedited access, surgery within 90 days, when we see patients with substantial risk of morbidity and mortality, a reasonable heart of reduced efficacy of surgery if it's delayed beyond 90 days. Patients with insulin, because we know that is an independent factor that predicts mortality, and some weight loss and metabolic improvement needed for a transplant, an organ transplant, for example, or any orthopedic operation. And the standard access are those patients with their conditions that probably will not deteriorate within 6 months with only mild dysfunctions or symptoms. So delaying those patients over 90 days probably won't reduce with significance the effectiveness of surgery. So the burden of disease is insulin use, kidney disease, high LDL, people using statins and blood pressure drugs, history of cardiovascular disease, congestive heart failure, and hypoventilation, plus obstructive sleep apnea. And if we put in a balance, we'll see balancing both. We'll see surgery really controls glucose, puts diabetes into remission through anti-diabetic effects and also weight loss, improves hypertension, even we have today level 1A evidence. It improves lipids, it reduces the cardiovascular risk, and it promotes weight loss. So we have benefits in patients that are really in need. So we came with this algorithm of bariatric and metabolic surgery for indications of surgery for diabetes and for obesity, and adjuvant bariatric and metabolic surgery. The priority of access, as I told you already, expedited and standard. And the patient's conditions would be, this is an example for diabetes surgery, patients with uncontrolled diabetes with A1C over 8 with 2 oral medications, or the use of insulin, history of cardiovascular disease, NASH, increasing cardiovascular risk because of albuminuria or stage 3 or 4 chronic kidney disease, over 5 years of diabetes, and those who can have standard access are listed here. The same with obesity surgery. The expedited access will be patients with BMI over 60. We put this over 50 down in Brazil because our average BMI is lower than US and Europe. NASH or other 2 metabolic conditions other than diabetes that increase cardiovascular risk, severe obstructive sleep apnea or hypoventilation, heart failure, and pre-dialytic patients. Standard access are here. This is another example. And adjuvant bariatric and metabolic surgery for organ replacements and to enable time-sensitive treatment for other conditions like coronary bypass graft, knee or hip replacements, back surgery, and infertility. Those should be expedited. I agree with Luigi that it depends on the region, it depends on the local conditions, we have always these questions, oh, sicker patients may use more hospital resources, but in places that we can resume operations, we have to have COVID-19 adapted hospitals, including the ICU. So separate admissions and some rules for accompanying persons and visitors. This is an example of our hospital. This is one building is COVID-free, the other is COVID-19 positive. So we have to adapt this while resuming those patients. And we always listen, oh, patients with those criteria, they will use more ICU. That is not true. This is a level 1A evidence show that in well-trained surgical teams, I'm not asking residents to do the operations, is the most skilled surgeon. In these very nice papers from John Birkemeyer from the Michigan Bariatric Surgery Collaborative, they show that well-trained surgical team carry less complications, shorter hospital admission time, and less use of hospital resources, including ICU. So most of those patients, insulin use or people with A1C over 8, or patients with BMI of 65 with sleep apnea, probably with very high skilled surgeons, they won't need. We're not talking to amateurs, we're talking to the real pros in bariatric surgery. So we won't need ICUs in most of the patients. And if we need it, we have to have a hospital prepared to accommodate all of those patients. What are the drawbacks when we compare the sicker versus the less sick? Remember the Brazilian Cancer Society, they put us as plastic surgery, cosmetic surgery. So there's some ethical considerations on the appropriate allocation of scarce resources. So if we have scarce beds, scarce ICU resources, well, I have to put patients that really need the operation, otherwise they're gonna die soon. Second, it's unlikely to obtain over time when the capacity of the hospital is low and other specialties are prioritizing their patients according to their urgent needs. And we're proposing to prioritize the cases where delayed surgery would make to prioritize less sick patients. I'm not calling them sicker versus less sick because we know that all our patients got a real disease, but proposing to prioritize cases where delayed surgery would make no difference can reinforce the misconception that bariatric and metabolic surgery is optional or low priority. Well, you can wait because these patients with a BMI of 37 with one drug for diabetes, his A1C 6.1, well, he's not a priority. So we advocate that bariatric metabolic surgery is not cosmetic. So this is a chance. This is a chance to show that, yes, we have much more priorities than most of our surgical peers. Finally, the advantage of the DSS prioritization algorithm, we serve the greatest need. It's not first come, first serve. It's really patients who need. Remember that paradox of the waiting list? So we have to be compared to cancer. And actually, long-term, we save more lives than oncological surgeons. This algorithm is designed to reduce the risk of harm from both baseline disease and possibly COVID-19 severity. We have compelling cases for prioritization of bariatric and metabolic surgery with other elective operations in times of scarce capacity. We are designed over a disease-based decision-making, and it's not purely, I'm gonna go for the 37 BMI with back pain. And finally, we expose the life-saving properties of bariatric metabolic surgery. This is the time to prove that we really do real business. Thank you very much.
Thank you very much, Ricardo. Our next presentation will be from Almino Ramos, also as introduced before, past president of IFSO and the Brazilian Society. And Almino, please share your screen, will be no selection criteria. Almino?
Yes. I'm sharing my presentation.
Okay.
So you have Nathan?
Yeah, we have it, but you need to like open it, like put it to run, like exactly down there.
Yes, in presentation format.
You have it, but it's exactly, now we have it. Perfect, thank you.
Okay, so you have presentation, you have the sun. We are good to start. Thanks for IFSO Latin America for inviting me to participate in this webinar, mainly to my friend Estuardo Berens and Luis Poggi, Sergio Aparicio, Nelson Rodriguez, Pedro Martinez, that are doing a great job organizing IFSO Latin America. Nathan Zundel, thank you also. And we are discussing something that I suppose is very interesting right now. We are planning to come back with bariatric surgery. And I think that this kind of discussion, I don't have any conflict to present here, are very important to orientate surgeons in different countries about what they have to do right now to restart and organize the bariatric metabolic programs again. So let's put my view about this issue. In the beginning of the pandemic, about 2 months ago, we have a huge expectation about number of cases, that we have a very great number of patients to be hospitalized, a lot of necessity of ICU, mechanical ventilation, extra use of PPE, and we have projected 1,000 of deaths regarding COVID-19. And this looks like to see that our healthcare system will be in a total collapse. And the first issue in the countries has done is to suspend what they consider elective surgical procedures, exceptions for oncologic, as Ricardo just presented, urgencies and emergencies. And this comes from counseling for the government to people to stay at home with distancing, with isolation. And with this, we have our hospitals and clinics totally empty. And no bariatric consultation, neither pre, neither post-operative. So with all these suspensions regarding our society's decision, the countries, our own decisions, and patients totally afraid to come to offices and bariatric surgery, we had, I think, a big problem with our patients in the bariatric metabolic field. Patients in recent postoperative period, they were without assistance, no multidisciplinary team support, surgeries scheduled, suspended or postponed. We don't have any access to complementary examinations to our patients, no new patients, and a poor follow-up to what the patients we have operated. So for a lot of surgeons, teams, people, that looks like bariatric surgery was prohibited, was suspended at this time. So this is our regulation in Brazil, our Brazilian National Health Agency. And this agency comes, and you can see that is March 17. And let me put in English so you can understand that every elective treatment in medical field should be suspended. Exceptions, chronic disease, and others continuated treatments that interruption or postponement can put the patient life on risk. And for me, this means obesity in this group of disease. But the main reason for that the National Brazilian Health Agency did this was because they are expecting a huge number of patients coming from COVID to our hospital, ICU, PPE. And so they could see that we could reserve hospital for these guys. And this is the reason to suspend elective procedures. It's not because the risk of the procedure, it's because the lack of hospital assistance for the risk for hospital assistance for the people with COVID. So when we could see this for the first time, there is some panic. Wow, I cannot do my procedures right now. And you know that panic is not a good counselor, and they can lead to bad decisions. So if we go and panic right now for bariatric surgery, we have to go back to open procedures, just sleeve gastrectomy, and with no energy, because this is what we could hear from in different webinars, 3-4 webinars a day, saying that, wow, take care with the gas, you can have diseases based on the gas, you should do just sleeve because you don't have to open a small bowel because you have the virus inside, and if you use energy, you have disease in the fog of your energy. So I think that we should stop and think. Number one, do we still believe that moderate to severe obesity and its comorbidities represents a serious disease that compromises time and quality of life? Remember, we have been saying this for 20 years. So we continue believing in studies like this. Obesity appears to lessen life expectancy markedly, especially among younger adults. Look this number. If you have BMI 22, your chance to go to 70 years old is 80%. If you have 40 to 50, this will be cut by the half. So number two, do we still believe in bariatric metabolic surgery as the best treatment for obesity, adiposity, and its complications? And we have a lot of supporting us in this issue. We have SOS study, we have this curve saying the cumulative mortality and the benefit of bariatric treatment for these patients. So I think that when we consider these points, we agreed in everything. But come on, this is a pandemic. Let's sit and wait that the virus will just disappear in a couple of months or weeks. Yes, we are ready for that. So let's go with the recommendations of IFSO. All elective surgical and endoscopic cases for metabolic and bariatric surgery should be postponed during the pandemic. Okay, that's right. Let's do it like this. But who will determine the end of the pandemic? When we will be in the post-pandemic period? And we have studies like this saying that this will not be this year, this will not be next year. Maybe we can improve in 2022, but we should be too prepared to face problems related to SARS-CoV-2 up to 2024. So come on, we have to sit and wait, and what we will do with our patients. And worsening this picture, we can see some reports coming from China, South Korea, saying that COVID is going back again with some new cases. So what we can do right now, I think that at first we have to have something very clear. To perform bariatric metabolic surgery during the COVID pandemic is totally different than to perform bariatric metabolic surgery in a patient with COVID-19. No matter what kind of procedure, if done in the acute phase of COVID-19, in a severe form, we will increase morbid mortality risk of our patients. And we could see this very clear in the famous Chinese studies and in two more Iranian studies. But we have one of these studies that are very pro bariatric surgery, because we could see that they performed 4 cases. You can see BMI 51, 50, 50, and 44, gastric bypass and bypass of one anastomosis, gastric bypass, and they did good. The patients didn't die. They stay a little bit more in the hospitals. They need ICU, but they survive it. So that's not so bad that we can imagine. But look, honestly, any of us would like to proceed with a bariatric metabolic surgery in an acute phase COVID-19 patient? I'm not. I don't want to do that.
No.
So would it be possible to operate patients safely in this pandemic period? Yes. The risk of bariatric metabolic surgery procedure itself will be the same. We will have the same result that we used to have in the past. So these patients, we can offer now bariatric metabolic surgery about the same risk, 0.2% of mortality. That was our number before. Complications and mortality of bariatric surgery continue to be the same and low than a cholecystectomy. So we need really prioritize something right now. Why? We have the same results. We have the same risk. So why we should prioritize? I understand, and the presentation of Ricardo and the idea of DSS is pretty good. But this is an idea of prioritization in situations that we need prioritize surgeries. And I don't think that this is the moment we need to go with prioritization of our patients. We have, this is the kind of prioritization we have right now, NIH criteria, and that's not ideal, but I think that's not the moment to change. And maybe in some places regarding the number of cases, the availability of beds in ICU or PPE or personal to work, maybe in places like this, we need to create some prioritization. But I think that if you have this situation, you cannot do, it's not question of prioritization, is that you cannot do move with bariatric surgery. Risk of bariatric surgery is the same right now. We don't operate a patient in acute phase or the patient will not be contaminated just after the surgery. So the risk is not based in the surgery. The risk of the surgery is the same we had before COVID. But the risk is to operate a patient in acute phase of COVID-19 or to operate a patient and this patient will be contaminated in the first days after the procedure by the virus. So what we really need is a reliable way to avoid a bariatric metabolic surgery done in a COVID positive patients or to have this patient contaminated in the first days after the surgery. Not really a prioritization system like this. And look, let's see, what is the risk? The risk is to operate a COVID-19 contaminated patient first, second, in acute phase, and third, with a severe form of the disease. So we need to combine 3 risks to operate a patient with COVID in acute phase and that this patient will develop a severe form of COVID-19. This will reduce a lot the risk of our patients. Another concept, and this was discussed here again, is to discuss the electivity of bariatric surgery. The same as oncologic procedures, and again, Ricardo discussed a lot this, as cancer, obesity is a chronic deteriorating condition. Patients don't need to be operated next week, but once they complete the adequate preparation, the surgery should be done. Suspension or postponement can seriously damage their health. But look, this is not a prioritization system. If the patient is prepared to be operated, I think we should operate. Luigi discussed also the condition of bariatric surgery as a semi-elective procedure that I like this idea also. This is another Brazilian health agency, and this agency, Anvisa, did some rules in order to come back with surgical procedures right now in Brazil. So you should look to your place to see what kind of risk you have. Low risk, less than 0.2% of population infection, medium risk in between 0.2 and 0.5, high risk more than 0.5. And to have an availability of 25 to 30% of hospital and ICU beds. Testing, it's a big problem because we know about problems with the different forms of test our patient. Again, I think that we should work to have bariatric surgery considered as an elective essential procedure. Different level of involvement will be necessary to do safe procedures right now. We should involve patient, family, healthcare professionals, hospitals, surgical team, multidisciplinary team. This is a big teamwork in order to have safety to our patients. And here, this is some hospitals here in Brazil, in Sao Paulo. All of these hospitals, all of them are working in to have exactly what Ricardo just showed us, and to have a totally aparted or separated area for treating COVID, and to have what we call an aparted COVID part of the hospital to be dedicated to do elective procedures. So we have a big list to check in order to can safely offer to return to elective procedures right now. And this is the number of patients I have been working in bariatric surgery since March. You can see that it's a bit more than 100 hospitals, mainly gastric bypass, but you can see that I have revisional procedures here, and I have associated procedures with bariatric surgery and cholecystectomy. The length of stay based at 1 day. And here we can see complications of this group of patients. Fever, and 3 of them, enterorrhagia or a bleeding in 1 case, re-hospitalization in 1 case, but you can see that we didn't have any problem related to COVID-19. The same as I think that we don't need any prioritization system right now. I think that we should continue doing what we think that is the best for our patient, no matter sleeve gastrectomy or gastric bypass. So I think we should keep the same rule. So in conclusion, COVID-19 is not here for a visit. It will stay for a while. We have in the better and quicker way as possible to adapt. Life must go on. Delay surgical treatment of obesity and its metabolic comorbidities can generate great harm for our patients, including compromise our time and quality of life, increasing morbidity and mortality. Bariatric metabolic surgery should not be considered simply some elective procedure. This is an essential operation capable to decrease overall morbid mortality, mainly coming from cardiovascular situation. And we have been working for 20 years to convince our peers, regulators, payers, patients, and families, general community, that bariatric metabolic surgery is from far the best treatment for obesity and its metabolic comorbidities. And stigma and access restrictive policies are not acceptable. I think that it's not time to give up. Thank you very much for giving me the opportunity to participate in this webinar.
Thank you very much, Almeno. We're gonna continue with the last presentation. Then we're gonna move to a second question of the poll, and then we're gonna have some discussion. So it's a pleasure to introduce a good friend and very active surgeon in the US, Prashant Vivek. He's gonna talk about MEND scoring in bariatric patients. Welcome, Prashant. You can become now a Latin American citizen.
Well, thank you very much, Nathan, and thank you, IFSO Latin America and Pedro for this very kind invitation. So I'm going to speak about using the MEND scoring system for resumption of bariatric surgery. So I think that the previous 4 talks, they have all said very important elements of truth. And there are very important takeaway messages from each and every one of them. But I think that the problem with what you've heard so far is that you are not seeing the big picture in the context of the pandemic. And I truly believe that if you use the MEND scoring system, it will really allow bariatric surgery to have equal footing with all the other specialties, all the other disease processes, because that is truly what the struggle is that we're facing. You heard Ricardo talking about how the oncological surgeons minimize bariatric surgery to be cosmetic. And I think that the reality is, with the biases that are there, our ability to argue for bariatric surgery versus orthopedic versus cancer versus cardiac, that's a very difficult argument to make. And so what we really need is a level playing field and transparency to really make our case. And I think that the MEND scoring system allows us to do that. So let me start by giving you a little bit of a background as to how we came about with this process. So at the University of Chicago, we stopped doing all elective operations on March 14 in anticipation of being able to handle the surge of COVID-19 patients. And in doing so, we automatically postponed over 1,000 operations. But at the same time, and I think that this is something that is too often missed in the midst of the pandemic, is that while we obviously have to have the capacity to manage patients with COVID-19, we still need to maintain the capacity and continue to provide care to patients who don't have COVID-19 disease. And I think that sometimes we've overcompensated and put patients without COVID-19 at risk in terms of not getting treatment. I think the other thing that we have to acknowledge and really be careful about is this word elective. In the context of the pandemic, when we say the word elective, the public and non-surgeons, what they hear is optional and not necessary. It's important to take a step back and remember that the term elective means that the surgeon and the patient have elected when the surgery is to take place. And that decision is based on necessity, effectiveness of the operation, consequences of the delay, and regardless of that timing, the need for the surgical treatment is still there. What makes COVID-19 so challenging for us in our regular decision-making about prioritization is we have to think about new factors that are just not part of our normal clinical decision-making. So we have to think about, for the first time, at least certainly in the US healthcare system, the fact that there are dynamic resource limitations that are changing week to week, month to month. Testing, PPE, ICU beds, ventilators, and so forth. In addition, and I think that this is a really important one, we have to understand that bringing asymptomatic patients into the hospital to have surgery risks the transmission of COVID-19 from patients to the healthcare team. And our colleagues and our residents and our nurses and our anesthesiologists are relying on us to have good judgment as to who should be undergoing surgery at this time, because we need to do our part to keep them safe as well. And then finally, we have to recognize that COVID-19, especially asymptomatic patients, they have an increased risk of having fulminant postoperative respiratory failure. And we have to really take that into consideration. There are a handful of case reports with bariatric surgery and others that have shown fulminant responses and unanticipated respiratory failure and demise because of this response. So we created a tool that really incorporates all these novel factors with the regular type of factors that we as surgeons are used to doing, and created this tool. And rather than use the word elective, we've eliminated that word, and instead we use the terminology medically necessary time-sensitive procedures. So in reviewing the literature from Asia and Europe, we identified 21 different factors that were associated with either poor outcomes with COVID-19, or increased risk of resource utilization, or increased risk of transmission of infection to the healthcare team. So each of these factors is scored on a scale of 1 to 5. And so if you add it all up, you get a total score between 21 and 105. And broadly speaking, these are grouped into 3 broad groups. And I'll go through some of these in more detail around bariatric patients later on in the presentation. Generally speaking, the higher the score for each factor, the worse the outcome with COVID-19, the increased risk of transmission of infection to the providers, or increased hospital resource utilization during the pandemic. Alternatively, with regards to medical necessity, if the score is higher, then either non-operative treatment is reasonably or more effective, or delaying surgery is a reasonable strategy to take. So how does this all sort of come together after you calculate this cumulative MENT score? Well, if you think about a hospital and an OR capacity to be able to do emergent and urgent cases, we know that whatever the status is in the pandemic, you still need to maintain that capacity. Beyond that, most healthcare systems have recommended maintaining at least a 20 to 30% capacity in excess to be able to manage surge with COVID-19. But in most systems, beyond the initial surge or beyond the peak, there is some extra capacity to do medically necessary time-sensitive procedures. And where the MENT score comes in handy is it allows you to set thresholds as to which cases can proceed and which cases you should probably hold off on doing. And so if a score exceeds a certain threshold, then that threshold indicates that those outcomes are worse. There's increased risk of infection to providers or increased resource utilization. And so in that circumstance, at that time, it is not justifiable to do those operations. But if the score is below that threshold, then it's reasonable to proceed. And the key here, as you see on this diagram, these thresholds are not fixed. They can be moved, they can be changed according to the resources, the circumstances that are there in every hospital, every state, every country, every region, every point of the COVID curve. This provides that dynamic flexibility that is so important with so many different changes and variables coming our way. So what we did just as a proof of concept is looked retrospectively at the MENT procedures that took place at our hospital before we created the MENT score. And what you see here in, designated in the green bars are these MENT cases that were performed. And these were all based on just ad hoc decisions by operating room leadership and department chairs and so forth. Now, these are very complex decisions to make. And if you're talking about making these decisions for 1,000 operations, that's almost an impossible task. But broadly speaking, you can see that the cases that proceeded had lower MENT scores with the green bars, whereas the cases that were not performed, shown in the red bars, had higher scores. So that kind of generally demonstrated the proof of concept that this actually matched up with how surgeons were generally thinking about this and making decisions. So the strengths of this process is that it's a dynamically flexible process, and it can be adjusted based on the resources and conditions in the hospital at that time. It systematically integrates these complex factors that, again, we are not trained and used to thinking about. And when we are not trained and used to thinking about them, it is very easy to fall back into our normal ways of thinking and our normal ways of making decisions. And in doing so, we don't necessarily make the best decisions. This is, for example, why we have checklists to make sure that we think about all of these factors in a systematic way. The transparency is very important. It provides reassurance to our colleagues, to the trainees, and to the public that we're not doing surgery because we want to get busy and make money again, but that their safety and the prioritization as to why they're having the procedure done is a significant concern for us, and resource preservation is being taken into account. It certainly offloads some of the emotional and ethical workload associated with this and risks It reduces the risk of moral injury. And I think this is a very key point. In our hospital system, all specialties have to complete the MENT scoring system. So it creates a level playing ground. Oncological surgeons, cardiac surgeons, orthopedic surgeons, gynecologic surgeons, everybody does this. Everybody knows what the scores are. And so there's not the fight saying cancer is more important than obesity, heart disease is more important than hip pain. It's all about resources and prioritization. And again, it can be used at any point in time along the curve. Now, obviously, this is a dynamic and ongoing process, so we still need to gather more data. And the factors that we initially identified undoubtedly are going to be modified over time. For example, obesity probably does need to be one of the factors that we didn't initially consider. So that'll probably be on the MENTS 2.0. That'll be coming out probably in about 3 or 4 weeks. Obviously, there's going to be some challenges with the appropriate weighting of factors, and getting a number that can give a false sense of reassurance and objectivity. And of course, we can't predict what future resources might be if a patient needs to be readmitted. But this is a really good start. And certainly in the US, the American College of Surgeons has cited this strategy. In our own state of Illinois and in California and Virginia, this prioritization has been cited as a reasonable approach for prioritization. A joint statement from the American College of Surgeons, the American Society of Anesthesiologists, Operating Room Nurses, and the American Hospital Association also cited the MENTS scoring system. So it's really caught on in the US, and I think that there's a number of healthcare systems around the world that I've had personal communications with that are also taking this into their prioritization concept. Now, as you saw in several of the earlier talks, there's a lot of interactions between obesity and severe obesity and the severity of COVID-19 disease. So how is it that MENTS really applies to bariatric surgery? So, one approach that was taken was with the IFSO statement that Almino presented earlier, which is that basically everything should be postponed during the pandemic. And obviously that cannot hold forever. You saw Ricardo present from the DSS, and I think that it really is important that they did describe and they did make the statement that we have to avoid that conception that obesity surgery is a last resort. But at the same time, I would say that I have to respectfully disagree with the preference of the sickest and the highest risk patients, because we are in a pandemic and we have to be cautious with the use of resources and make sure that there is sufficient resources for everybody. And this is probably the most difficult thing for surgeons to come across with, because we are so conditioned and used to advocating very strongly for our individual patients, and our ability to think globally in the healthcare system term is not so easy for us to do. So here's the patient factors with the MENTS scoring system, and you see the scores 1, 2, 3, 4, 5. So with our bariatric patients, they tend to be younger. So I've outlined here in the red boxes sort of the average bariatric patients, if you will. So they tend to be younger, so those are somewhat lower scores. They don't generally have intrinsic lung disease. Certainly they have sleep apnea, and they may have some cardiovascular disease. Certainly diabetes is common, but remember 70% of obesity patients do not have diabetes at the time of surgery. They're not overtly immunocompromised. Obviously, we're not operating on patients with influenza-like symptoms or COVID symptoms. And as far as exposure goes, and remember, this was done prior to the availability of preoperative COVID testing, that's also taken into consideration. So if we think about a higher score being associated with a poorer outcome, with regards to patient-specific factors, bariatric surgery patients are kind of in the middle to lower range of the score. Now, how about the procedure itself? Again, looking at these different factors, bariatric surgeries are relatively short. They have relatively low length of stay, very rare ICU use, very little blood loss, very small surgical teams. You don't need to have 4 or 5 people scrubbed in to do the case. Obviously, all of these cases are done under general anesthesia, so the need for intubation is high. And the reason why intubation is weighted so high in our scoring is because that is a high-risk situation for aerosolization and transmission of infection to the healthcare team. With it being abdominopelvic minimally invasive surgery, postoperative respiratory compromise is minimized, and so if a person develops COVID-19, that risk is less. Now, what about the disease itself? So the first two factors here are a comparison of the relative effectiveness of non-operative treatment, as well as the relative resource use and risk of exposure. And I would argue that for patients who are seeking bariatric surgery, by definition, non-operative treatment has not been effective for them. So that automatically gives them a lower score. Now, certainly in our MENT scoring, we looked at 2 weeks and 6 weeks as two separate points in time to try to take into account which cases should be prioritized. And it is true that not too many of our patients really will have a significant worsening in their disease or increase in the surgical difficulty by waiting 2 weeks or 6 weeks. So that's going to end up being on a higher score. But cumulatively speaking, the average bariatric surgery patient actually has a relatively moderate to low MENT score. And so in the whole context of all the other specialties and other disease processes, we are actually right in the middle and should be prioritized just as much as many of the other sorts of procedures that you heard about discussed earlier. Now, one of the challenges that we have as human beings is that we have a very distorted sense of time, and especially in the midst of a pandemic. One day can seem like a week or can seem like a second. And even when we came up with the MENT scoring, we only chose 2 weeks and 6 weeks as postponement of care. But knowing now that the pandemic is going to be with us at least 18 months, we have to acknowledge that non-operative treatment of obesity not only is going to be less effective during this time, but we know that people will gain weight during the pandemic because they don't have access to gyms, they don't have the same sort of activity opportunities and diet and so forth. And so, you know, there's a hashtag quarantine 15 referring to the 15 pounds that people can anticipate to gain weight. And if we're talking about this time horizon, I really do think that the concept of reducing risk to manage the second surge in COVID-19 that's going to come in the fall, it's going to be important. And patients who have had surgery, obesity surgery, will be at lower risk of bad COVID-19 outcomes. We know the cost effectiveness argument is clear, at least at 10 years. And the reality is that more people die waiting to have bariatric surgery than after undergoing surgery. So putting this all together, certainly obesity and several of its comorbidities is associated with poor COVID-19 outcomes, but bariatric surgery is incredibly safe. Hospital resource utilization is relatively modest. And by definition, patients who are seeking surgery, for those patients, non-surgical treatment has not been effective. And so when you hear about bariatric surgery being deprioritized, really to me that indicates implicit bias more than any other thing. But having said all that, we cannot be business as usual. So in addition to having this prioritization scoring, we at the University of Chicago have mandatory preoperative testing, 48 to 72 hours before surgery with preoperative and postoperative sequestering. We do have some same-day testing available with 4-hour turnaround time. The role of antibody testing is not clear at this point. We too have visitor restrictions, universal masking, screening at entry, and we have separate units as well for COVID-19 patients. And in the operating room, we actually, everybody except for the anesthesia team actually leaves the operating room for 10 minutes after, at the time of intubation and at the time of extubation to reduce the risk of transmission to the healthcare team. So I want to thank you very much for the opportunity to talk. I wish that we could stand shoulder to shoulder like in the good old days, but hopefully soon we'll be able to get back to that point. So thank you very much.
Thank you very much, Prashant. Thank you very much, everybody. So we're gonna go for the second question as soon as you stop sharing the screen. Pedro, we're ready for the second question for the pod. There you go. Are you planning to perform bariatric surgery in next 30 days? Yes, no. What kind of criteria for selection will you use? No selection criteria, low morbidity, high morbidity. Perfect, so we're waiting for for the result for that one, and then we're gonna start the discussion. The co-moderator for this part will be Nelson Rodriguez, that I think I saw around, and Pedro Martinez.
Here we have the results.
And there are the results. So do you have the result for the first one, Pedro, that we can see both?
What is high morbidity and low morbidity? Patients that have more risk or less risk?
High morbidity is more risk.
So we're doing cases that surgery does not add anything to them. I think people here it's a confusion between eligibility and prioritization. To be eligible, we have criteria since 2000 and something, 1991 NIH. And metabolic surgery, we have 2015, the DSS consensus. So I think a point should be clear. To prioritize patients is not to select eligible patients. That's completely different. It's not, I think it's a confusion.
I will ask the panelists because I can see them all. So I'm gonna make some comments and questions.
Pero amigos, ¿qué está pasando? En Warzone empiezan los secretitos, los eventos, las cosas gordas. Resulta, chicos.
So when you want to speak, let me know and then raise your hand, then I can give you the word. So the first thing for me, and this will be a comment that was confused to me. So if we only do the low BMIs, no high risk, etc., are we asking the oncologists to do only the small tumors, the tumors that are very resectable, easy to do? Are we asking that? It's not the same. So that will be my first question. So we are only, I mean, you heard my theory about chaos. You can start with a normal case, it bleeds, something happened, you have a disaster there. And partially I agree with the comment of Ricardo Cohen that if well-trained group, this is no moment to train people. That I agree, and I will start with that one. This is not moment to train people. But should we select just the easy cases that we don't even know what is an easy case? That would be my first question. Second, we're learning from our own experience. It's very subjective, but we are studying it now with Camacho's group in Montefiore. We noticed that patients, even with coronavirus, that they are asymptomatic, they are not transmitting the disease through surgery. Only symptomatic coronavirus patients are transmitting the disease. And I think that we'll learn soon that one, so that will make a change of the selection that Dr. Vivek just presented to us, but I will like the score, so we're gonna discuss that too. And at the end, and this is the first question I'm gonna ask everybody, is from our own experience, when we're getting back to elective surgery already 3 weeks, are the patients the only one who are selecting if they want the surgery or not? It's not us, it's not the hospital. We call every patient, and the patient, some they don't want to come because they're scared of the virus. Some they don't come because they lost their job, so they don't have insurance anymore. So they come because they want to take care of their family, their parents, their kids. And a lot of them, they call because they want to have the surgery now because they don't have to go to work and they are kind of in a free time to have the surgery. So what is your own experience related to that? Prachand, are your patients deciding by themselves if they want the surgery now or not? I'm talking about the elective patient that you already in your list. Are they deciding? I'm going to start with you, Prachand. What's your experience?
So what we've done is we went back and looked at the bariatric cases that were immediately postponed on March 16th. We used that to prioritize. So we started calling the patients that spoke to them, had this process for decision making, went a long ways, because essentially what you're doing is you're asking somebody to come to the hospital after all the instructions that they've received is you have to stay home, you have to stay home. So how do you flip the script and suddenly make it saying, oh, you really should come in? And so not only telling them that there's an important process behind why they were chosen to come in, but also emphasizing the safety measures that are in place at the hospital in terms of the preoperative testing, in terms of the visitor restriction policy, the separation of COVID patients from non-COVID patients, and so forth. That goes a long way. Now, having said that, I would still say that more than a third of patients will just refuse and say, you know, I'll just wait another couple of months, which is perfectly reasonable to do. But to your first question, Natan, I just wanted to make this point. As far as like, do you do high comorbidity, low comorbidity patients first? I think it's a matter of balance. And in any particular patient, you can choose to, for example, do an operation on somebody who's an insulin-dependent diabetic because we know the effectiveness of the bariatric operations. But then the other factors should be lower risk, relatively speaking. So for a younger patient, for a patient without sleep apnea, for those other things, if you balance that out, then in the context of the healthcare system and the resources that are available, it makes sense to proceed. Similarly with the cancer, if it's asymptomatic, you could potentially postpone. But a near obstructing colon cancer that's about to cause obstruction, then you have to proceed. So I think that using a prioritization process that looks at all these different things and not just within the specialty, it's a really critical part of moving forward, because the evidence is overwhelming and compelling, and you've seen it presented over and over again, but we're still at that 1%, 2%. We have to create a level playing field that decisions are being made fairly and transparently across the board.
Thank you, Vivek. Ricardo, are you seeing the same problem with your patients when you do them? What's your experience? Are you thinking if the numbers in Brazil keep increasing, that I think is also sometimes panic created by the people who doesn't like your president? But how do you approach your patients, and are they allowing you to do surgery in them? Are they relaxed with the risks?
Actually, I have to agree with you that there's a lot of panic and a lot of politics in our corona crisis. We're just a little bit delayed in our curve. The private hospitals that were prepared for 500 people at the ICU, they have 80, 70, so it's not overloaded at all. And we, in our hospital and some big private hospitals, the public hospitals are not the case because they're full of COVID-19, because they're a referral center for that. But in the private hospitals that I showed you, we can split into two different hospitals. And I can tell you that we resume doing cases. It's not a volume as the usual, it's not usual business at all, but it's much more easier to convince a patient with albuminuria, with sleep apnea, with using 200 or 100 units of insulin to go to the hospital than patients with 40 BMI with back pain or reflux. What I did around 12 cases in 3 weeks, that's almost nothing, but 11 of them were patients with high risk. They spent 30 hours at the hospital, they went home. Most of them were using insulin. We are a diabetes referral center. Okay, it's a biased institution. However, it's much more easier to convince these patients than convince people with no comorbidity at all to go for surgery. We don't have problems with overtime. We don't have problems with beds. We don't have problems with ICUs. We have 45 beds, surgical intensive care units. But for me, in my experience, it's easier to get patients, the really sick patients, and I could convince some internists in our hospital, look at bariatric surgery is not cosmetic. Bariatric surgery really saves lives. Because again, what Almino showed and what Luigi showed is it's not different than eligibility. I can show you all the eligible patients. We know BMI were 40, 36 with 1 or 2 comorbidities, 30 to 35 with those DSS criteria. However, it's not the case. We're not talking to patients that can be operated, but those who need to be operated.
Luigi, your experience in Italy regarding people losing insurance, economical crisis, scare, all the factors. When you started Elective, you call your patient. What is their response? Are they selecting themselves or not? You see any of the factors we mentioned?
I must confess to you that we have started gradually over the last 4 weeks. This is the 4th week that we are working, and there were no real problem in recruiting patients that were scheduled for surgery before the pandemic. So we did not find any problem. But for the reason I explained before, we choose to do the more standard operation, the more simplest operation. Of course, I don't understand Riccardo's statement, the difference of eligibility and prioritization, but I understand that you diabetic surgery surgeons are scientists, are clever, are smart, but this is much simple. It's a simple situation that as Dr. Prashant stated, in my practice, 15 to 20% only of the people are obese, are diabetic, and a minority of those 15-20% come to me for diabetes. They come because they are obese. So I think that in this situation, there is no point to make a lot of speculation, diabetes, cardiovascular, nephropathy, retinopathy, but we know all that. We have been telling this. It is sad to say that since, I guess it was 2007 or 2008, that Rubino did the first diabetes summit in Rome. I attended that. Over the last 13, 14 years, we have seen very little improvement in the referral of diabetic patients to bariatric surgery, to surgery. So I think it is good to point and to refocus this situation. But at the end of the day, this is a different matter. This is a matter that I left the National Health Service. I am in a private practice. They said you can restart. You should choose how to restart. I want to start normal standard of care case, simple cases, do that, send them home. And this is, there is not much science to do. It's a simple condition. And fortunately in Italy, we have no problem regarding insurance because the National Health Service is covering in all the national public hospital, but is covering also for some private hospital like my hospital. So I don't see problem. The real problem is still in the Milan area where I was operating, where now everything is still stopped and is not going to restart till the next 2 to 3 weeks. But I guess they are going to restart with standard cases.
Thank you very much. Before allowing Ricardo to answer, Almino, we noticed you still doing cases comparable with your cases before. This 110 in the same period last year, you've done how many? You did 111 since March. In a normal time last year, how many cases will be representing that period?
This is about 30%, Nathan. And I'd like to tell you about something, because you are talking about patients that they cannot come and do the procedure. But let me tell you about the opposite situation. We have some patients that they look and they say, look, doctor, I am at home, I'm not working. I am ready for doing the procedure. I'd like to do it right now because I will save time on my life. Another ones, they say, look, I'm not sure that when I go back to work, I will keep my work. And if I don't have work, I don't have insurance. So let's do my procedure right now while I'm sure that I can have insurance. Another, they say, look, let me do my procedure right now, because when I start work, I will not have time for doing the procedure. So in the same way, we have a big group of patients saying that they cannot do, they don't like to do the procedure right now. We have a group of patients saying that, look, that's perfect for me doing the procedure right now because I can save time. I'm at home.
Thank you, Almino. I will ask now, Ricardo can answer, but from my point of view, I think if we are ready to do safe surgery, we can do any case if it's safe for everybody, is what I'm saying. So I wouldn't take risk with low risk, high risk. I think we need to make sure that it's safe. And some people are proposing outpatient surgery. I'm a little bit concerned also about it because you don't know fully the situation at home. All we know, and I will ask first Ricardo and then the other panelists, if you, especially probably Prachanda, they are in the same region that we are with all these lawsuits, did you modify your consent form according to COVIDian? Because we did. We asked now in the consent, we put the temperature of the patient saying he doesn't have symptoms, and also understanding that he will be tested before and after, and he needs to be responsible at home before and after of contacts. So Ricardo, please answer, and then let us know about the consent form later. Ask Luigi. I mean, you can answer Luigi, and then tell me about the consent form, and then we go from the other ones.
Nathan, before Ricardo answer me, because I will not talk anymore, let me also say that I definitely made a reflection over the last 3 weeks, and I'm considering much more banding surgery these days more than before because of the simplicity of the operation. And if people are coming to me asking for this kind of procedure, I am also very happy. And I also think, going to your creation and invention, that Bariatric would be interesting in this time, because we can do a lot of speculation about bariatric surgery, but for me, I've been in the field more than 25 years, and I've seen doing and redoing and re-seeing the same patient, and I've done Roux-en-Y for the last 20 years, but I still see patients coming back with the bypass with problems. So I think that also the benign kind of in temporary surgery, let's say in inverted comma, because all the procedures are temporary, should be reconsidered in the COVID era. Thank you.
Ricardo?
What I think that we can say about all the presentations is that what's closest to our DSS recommendations is Vivek's one. What Vivek proposes is something in the middle, in places where you can operate eligible patients. And eligibility means patients with BMI over 40 can be operated. But those patients, if they wait a year without any comorbidity, the risk of getting worse of obesity is much less than a patient who takes 100 units of insulin. This is what I mean between eligibility and between prioritization. If yes, it is, Luigi. If you see patients from the oncological surgeons with a prostate cancer Gleason 7 that can wait months, they won't prioritize those patients. They'll do the higher stage patients. So this is what we need to do, is to show that metabolic and bariatric surgery have time-sensitive patients that needs to be put first, and not to come and be served because they were in the waiting list. I'm the first one, but I have 36 BMI with reflux and infertility. So that's not the point. Those patients can wait because their disease will not get worse. While people with previous cardiovascular disease, people with kidney failure stage 3, where 6 months can make them undergo dialysis, this will make a huge difference. So doing this according to your hospital, I can agree that you can do, like Nathan said, do easier cases or tougher cases. However, tougher cases will really benefit much more in a short term than patients with no comorbidity at all. This is the difference between eligibility and the difference between prioritization. I prioritize patients that have time-sensitive risk. If they're gonna get worse in 3 months, those are priorities. If they will take a year to be prioritized, hopefully COVID-19 will be much less intense in your region. You can do whatever you want. But patients right now with scarce resources that may die within 3 to 6 months or undergo dialysis, they should go first. And the informed consent, yes, we changed informed consent about respiratory symptoms and the risk of COVID-19 in hospital and the need of quarantine post-op is a huge informed consent. Yes, we did change it. Unmute, Nathan, you're mute.
Sorry, Prachand, did you change your how you modify your consent?
Yeah,
But also, are you concerned about, is your hospital, your system, yourself, concerned about lawsuits getting the COVID when they went to the hospital? Because as you see now in TV, all the lawyers are already aligning themselves to sue half of the country for the coronavirus. So how are you handling that?
Yeah, so I would say that we are, I think, less concerned about the lawsuit part, but we also, I think that the way to prevent lawsuits is to really make sure that your patients are as informed as possible. So acknowledging the uncertainties about COVID-19, acknowledging the fact that even with preoperative testing, the false negative rate of asymptomatic patients undergoing COVID-19 testing is 20%, maybe 25%. So part of our informed consent is acknowledging those unknown risks. We also talk about the visitor policy because you know, that's something that a lot of patients struggle with. And of course, the inability to anticipate a month from now what the resources might be.
Thank you, Prachand. Almino, there is a question from the audience. What do you think about asking chest CT scan before taking the patient to surgery? Any use for that? You think it's worth it? It's cost effective? What do you think, Almino?
I think this issue of how to do the diagnosis of the patient is right now is a little controversial, no? Because we know that we cannot trust really in the PCR. So I think that when we join PCR and the scan of the test, we are including more patients. In this group of patients, I had 3 that they tested, they were not operated, they tested by PCR positive before the surgery. And that's important to look for these patients because 2 of these 3 patients, they were totally asymptomatic. So probably without the test, we will proceed with the surgery in these patients. But I think that the scan, the thorax scan alone is not so good. So we should use with the PCR. And even though I think, Nathan, that when we consider all of this situation, we have to be very sincere and say that right now, over 20 years, the risk of our bariatric surgery will increase a bit because no matter the test you can do, no matter the combination you can do, you can have the chance to operate some patient in a positive phase of COVID because it's not 100% trustable, this kind of tests.
Yes, thank you, Almino. Prachand, any use you see for the CT scan of the chest?
No, I think that an asymptomatic patient getting a CT scan is probably not helpful. It's more for patients with symptoms.
Last questions for everybody. This is the last question I'm gonna make. This is an important question to me. Is how do you envision your residents, your fellows, that they're actually working with you to finish their fucking training if they cannot do cases? And I agree, I wouldn't allow nobody learning to do, at least in this gap of period until we are safe, to do cases. How are you handling that? I'm gonna start with Ricardo. How are you handling that?
We don't have resident fellow, but we have some junior assistants in our team. And the two juniors are suffering a lot because they won't do the cases within the next months. And each of them did, I think, 10 or 20 gastric. One did 20, the other did 10 gastric bypass. So they are in training. So what I can tell you that, yes, residency will suffer a lot. The Brazilian College of Surgeons is petitioning the National Residency Committee to extend the residency period from the pandemic and on. So they're discussing how to do this because actually they won't learn a lot with this pandemic because everything stopped. Our main hospital at University of São Paulo, which is the most renowned residency, is a COVID hospital, 100%. So those guys who never learn how to do a hernia, a gallbladder, reflux, and never bariatric surgery. So it's a huge problem. I agree, Nathan, we have a problem. Houston, we have a problem.
Luigi, you have resident fellows.
I can tell you that in northern Italy, most of the residents were involved in the COVID practice. They were totally absorbed. They stayed in ITU, in the unit. So the situation for them was a very tough period. Also, the surgical residents were kept in ITU for assisting the COVID patient. In southern Italy, where we did not have so much virus, most of the residents have been on holiday. They are enjoying their holiday.
Almino, your experience with your juniors, fellows, residents?
Nathan, I think Ricardo will agree with me. This will be a big problem in Brazil. Because look, the surgical training here, mainly and I'm talking about public hospitals, the surgical training stopped in February. And this will not come back before next year. So this year will be lost for training surgical residents in Brazil. And talking about bariatric surgery, all of the beds in public hospitals in Brazil right now are used by patients with COVID. So I'm not sure when digestive units and bariatric units will be able to recover these beds. This will not be easy. It will take years. It's 2, 3, 4 years to go back for the same situation we had in surgical training programs in Brazil than we had in December 2019. It will be very, very difficult.
Rachad, your experience?
Yeah, so we know that there's been a 70% drop in cases performed across the board, not just bariatric surgery. So the cases that are still being done, we do involve residents, but I think that what we do is really break down the cases and just leave the attendings to do the more complex parts so they can be done more expeditiously because time does matter. But at the same time, they do need to have some opportunity to get experience hands-on, get their hands moving and so forth. I think that the educational bodies, ACGME and so forth, recognize the challenges and the total case numbers that are required for completion of residency have been modified to take into account the changes since March, but nonetheless, it's less about the credentialing, it's more about the experience and the education they receive.
For me, one of the biggest problems that I've seen since this pandemia or panic endemia, because they both started simultaneously, since this started is because nobody knew or nobody knows enough. Everybody jumped to conclusions too early and do some crappy stuff like, we better do open, then people start to do open surgery, and now we know it's safer to do laparoscopy than do it open. and every society want to jump first and give some indications without proper knowledge. And the presidents of the countries are doing the same. So I think we learn day by day. I think what we're discussing today may be different in 10 days or 15 days. You know, because you see people saying that the cases are coming back in South Korea, but when you look deep, it seems that people who got the disease, they don't get it again. So it's just people who came visiting from somewhere else, etc. So we don't know enough. So I think when you don't know enough, we as surgeons, we need to focus in make sure that our surgery is safe to protect the health people who work with us in the OR, to protect the patient not to get that specific disease, and the usual safety we give to all of our bariatric patients. So I think if we can control that, the discussion of who I do first will end up being also a patient decision. I have the insurance, I can do it, I want to do it now. So I'm not sure. I know Estuardo wants to say the final goodbyes. For my part, I want to thank everybody. It's been very amazing to me to see how people from different parts of the world, we actually think alike in many things, but we differ according to our own situations and our own practices. Estuardo?
Just Luigi, you want to say something?
Yes, just because I was very surprised by the prediction of Almino that in Brazil things will go back to normal in 3-4 years. I mean, in Italy we had a very bad rate of infection, but I mean the public hospitals are still suffering, but they are gradually going to normal. I guess in maximum a month, everything will restart normally in the hospital, in the university hospital, in the residence, in every field. I don't understand why are you so. Do you have such a negative prevision of 4 years to go to normal?
Luigi, this is about bariatric and metabolic surgery. And what we have to think is that in general, the units of bariatric surgery in the public hospitals here in Brazil, they have just a few beds. They have 3 or 4 beds for the unit of bariatric. In general, they are part of the digestive unit. And right now, this digestive and bariatric beds, they are being using for the clinicians. So right now, these beds are not from a surgical treatment so far. So I'm thinking that we are talking about a system that is the public system that is working with 98% occupation rate. So the clinicians, they will continue having patients to use these beds. So what we have to do is to convince the clinicians again to give back these beds to us, but they have patients to put in these beds. So it will be a big fight from surgical department with the clinical department in order to recover the beds that they lost regarding the COVID pandemic.
Okay.
I have a question for the panelists. That statement said we need to have a deceleration phase or flatten the wave before we start the surgery. But what we can see in our region that we have no hospital resource limitation. So how we to wait until flatten the wave or deceleration, or we can restart the surgeries?
I think, Pedro, I will answer before you ask the other ones. I think it's part of what I was mentioned before. Nobody know, everybody make up something, flat the curve. We were told that 2 million people will die in the US when this started. Yes, we're gonna have like 90,000 people dying. That is a lot, but it's not what people tell you. I think, and I mentioned this before, that is a philosophical question that I'm gonna wait for the others to answer. I will say, a philosophical question, not living is worse than dying. And that's my opinion. So you cannot stop life, especially with physicians say, stay at home, I take care of you, the hospital, you take care of me, stay at home. That's very easy to say when you have food in the refrigerator and you don't have kids to feed. So life has to go on, you know, this is part of the nature, but that's my opinion. I don't know the others' opinion.
What do you think, Ricardo?
If I understood the question is, if you have scarce resources, if you should resume surgery, is that the question?
No, if you need to wait for the curve to go flat before you start surgery, or you can...
This is why if you had dedicated bed, a few beds to operate patients, and you're gonna compete with cardiovascular surgeons, cancer surgeons, you have to prioritize. So yes, you should resume and do the cases that need time because they're time sensitive. If you wait for them, if you wait 3 months, 4 months, those patients want to go dialysis. They may die, they have a heart attack or stroke. So I think you should not wait to flatten the curve. I think you should prioritize the patients. And of course, if your hospital is not our public hospitals, like Almino mentioned, overloaded with COVID-19. If you had some ICU beds reserved for this, although they don't need ICU resources in 99% of the cases, you should prioritize patients and resume life. And I agree with Nathan. It's a lot of panic, stay home forever. This is something weird.
Jose Rodriguez from Mexico said, if we have no hospital resort limitation, we have beds on the ICU, we have no problem at all. Less than 10% of our hospital with COVID patient. Do we need prioritization in that cases also?
No, it's a different thing. What we're talking to prioritize in regions where there's scarce beds, scarce resources. But if your hospital has 10% of COVID patients, tons of beds, free ICU, no competition between specialties, of course, do the eligible cases. You don't need to prioritize.
Exactly. Prioritize cases is one thing, prioritize resources is a different one.
It's different.
And that's what we said at the beginning. Every hospital, every city, every country, every surgeon has their own limitation regarding to that one. You know, but what I don't agree, and Luigi is here, is a witness, that I don't agree is Italy is the country where more health personnel die from the disease, and we assume they were sent very early with not the proper protection for whatever reason, and that's what I totally against it. You know, when you see people in some of our Latin American countries using plastic bags to protect themselves from liquids, I wouldn't work like that, you know? So I think that that's what resources is one of the other reasons to prioritize. Estuardo, we run out of time, Estuardo? Yeah, okay.
Yeah.
Thank you, everyone. After 2 hours, we are still here and 63 participants. So for you, thank you very much. Nathan, thank you very much for the moderation. And Luigi, Almino, Ricardo, Prashant, Nelson, and of course, Pedro, my dear Luis Pollo and Sergio Aparicio, thank you very much for sharing with us. So see you in 2 weeks. We'll have a surprise for you. Right, Nathan? Good surprise.
A surprise from Nathan? Wow. I'm out.
He's going out.
Never is good. A surprise from Nathan never is good.
No.
Be wearing PPEs for my surprise. Be wearing personal protection equipment.
Thank you very much, gentlemen. God bless you all. Thank you.
Nathan,
Bye.
Hey, everybody.
Guys.
Nathan, ask you
Bye.